privilege.
So your mic is on mute mode, sir.
Very good evening to all the postgraduates who have joined. I take special privilege today in welcoming Dr. Sagar Bhargav, who we are all now familiar with. All the postgraduates must be recognizing him from the couple of presentations and the moderations he has already done over the past few days. We also have with us Cornea Specialist Cornea Chatterjee, both are consultant at BBI Foundation. We had a presentation on anterior segmental and dry eye by Dr. Bhasker, which we will have to shift to another day because his child is not well today, and we are praying that she gets well soon. Dr. Sagar will be speaking on TOPO, PENTACAM, and SPECULAR, and I would like to request Dr. Sumanna Chatterjee, please formally introduce Dr. Sagar Bhargav, please.
Thank you, Dr. Sinha, sir. It is a privilege for me to introduce Dr. Sagar Bhargav. He is a senior consultant in BBI Foundation, Kolkata, and director in SLR Eye and Retina Surgeons Private Limited, Kolkata. He completed his MBBS and MS from Government Medical College, Aurangabad, had many accomplishments, prominent being Dr. Pandit Palikar Memorial Prize for standing first in first MBBS University examination in 1995, Dr. Balchandra Mukund Dandekar Memorial Prize for standing first in the subject of ophthalmology in third MBBS University examination in 1998, Dr. R.L. Balchandra Memorial Prize for securing highest marks in MS Ophthalmology University examination in 2003. While working in Shankara Netralaya, Chennai, he was recognized as the Best Associate Consultant for the year 2008 and conferred the Dr. T.L.K. Rowe Endowment Award. In the year 2008, after successfully clearing the examination, he was conferred with FRCS Glasgow. He started LASIK Center of Shankara Netralaya in 2011 and was the first to use the femtosecond LASIK, that is bladeless LASIK, in East. He has been actively involved as speaker and panelist in glaucoma education programs organized at different levels. He has also been a team for conducting instruction course on cataract at ASCRS. It is our privilege to have him as a speaker on very important topic today. Over to Dr. Sagar, please.
Good evening, all. Thank you so much, Dr. Satyajit. Thank you so much, Dr. Satyajit, for this invite for another talk. And it's always a pleasure to be amongst the graduates who are just beginning their career. Thank you, Sumana, for such nice introduction. So let us start our topic of today. We will be starting first specular microscopy. Since Dr. Bhasker is not there, I will take a liberty of exceeding my time limit. I was supposed to speak for 30 minutes, but I think I can go a little longer so that we cover this topic in greater details. So I'm just going to share my screen now. Am I audible?
Yes, you are audible.
Yes.
Great.
I want the postgraduates to know that this will be the most one important thing that you will be needing in your future life. As far as cornea is concerned, topography, pentacam, specular microscopy is something you will have to deal with every day. It will be useful in your cataract surgery, in your LASIK, all those who take up cornea. This particular talk will be very, very helpful to you even after your exams.
Is my screen visible?
Yes.
Yes.
Yeah. So, so the first topic is specular microscopy. Let me start with this example of a 75-year-old gentleman. He came to me for a second opinion and he gave history of fluctuating vision with a near vision difficulty. Now, his best criteria visual acuity unaided was 6/9 N8. The problem was fluctuating vision and near vision difficulty. On examination, actually, what we saw was there were gate changes. Specular microscopy, the cell counts were less, and pachymetry was more than 600 microns. So the point here is that clinically, this Fuchs endothelial dystrophy was missed preoperatively, and one simple mistake actually ended up in a very unsatisfied patient. So whenever you are advising cataract surgery, please make sure that you don't miss the clinical evaluation of the endothelium. Specular microscopy, whether it should be done in all the patients, we will see that the other thing that was because we missed the first thing, we took a wrong choice of the lens, and that's the reason why patient was so unhappy. So this will be the scope of my talk. I think I'll be covering all these things, and this I think should be more than enough for your at your postgraduate level. Plus, this will give you a very good insight as to how you will deal with patients in your OPD. So as we all know, specular microscopy is a non-invasive photographic technique that allows you to visualize and analyze corneal endothelial cells. It's basically an instrument which projects light onto the cornea and captures the image that is reflected from the optical interface between the corneal endothelium and the aqueous humor. And approximately 0.022% light is actually reflected from this interface, and this is what is captured by the instrument and displayed as a photograph. Now, when do we do this specular microscopy? So essentially, there are three broad categories in which you can group this indication. So first is the actually understanding certain changes in the endothelium, which will help us to formulate a diagnosis of Fuchs, posterior polymorphic corneal dystrophy, and ICE syndrome. Then in certain preoperative interventions, when you are going to take a patient for some surgeries, most common is cataract, but you can have even secondary interventions like secondary IOLs. So these are the lists where you would actually want to do a specular before taking up the patient. Please understand one thing, that you don't have to do specular in all the patients who undergo cataract surgery. Absolutely not required. These are the lists where you will consider doing a specular microscopy. And the third is to assess the donor corneal tissue. So when we talk about specular microscopes, essentially there are two types: contact and non-contact. Obviously, non-contact is the one which is more popular. And once you have this, once you capture the image, there are three forms of analysis of the cells. One is the automated, where machine does everything. Second is what is called as semi-automated. Here, what happens is the machine has an inbuilt default cell size. In semi-automated, what you can do is you can change the cell size based on what impression you see on the gross photograph of the specular. So suppose the most common pattern is S, the small size. You can increase this small to medium, large, or XL. So based on your clinical impression. And the third is manual. So manual can be further. Manual can have further options like fixed frame analysis or variable frame analysis. So fixed frame, as the name suggests, that you count the number of cells manually in a fixed grid. And a variable frame analysis would mean that you will actually define the area of analysis by outlining the cluster of cells, and it is done if the area of cells is irregularly shaped and does not fill the frame. Then there is something called a center method, where the cells, the center of each cell is marked, and then the counting is done. And the flex center method, where actually you mark the first outer boundary of all the visible cells are marked, and then the center of each cell is marked and manually, and then the analysis is done. So this is something that one should remember. But one important point is that as of now, most of the machines do automated analysis. So really, this was probably about 10 years back where this was more common. Now, what do we assess in specular microscopy? So essentially, you do quantitative and a qualitative assessment. Quantitative, basically, you're looking at cell size, shape, and number, and qualitative, you're looking at certain abnormal cells and patterns. So this is what typically specular microscopy printout comes. So what you need to see is the name of you need to basically, if this comes to you in an exam, you have to tell the name, tell which eye this is there, and what is the captured position. So this is important. So whether it's a central, peripheral, or mid-peripheral, where exactly it has been captured. This is the photograph of the endothelium. This is how the machine has traced the endothelium. These are certain parameters which we will discuss, and then there are some graphs. So we will go into details of all this. So this is what I was telling you. You can have now this one is from TopCon. Each machine has their own way of doing it, but in general, most common is the central photo. So machine automatically aligns to the center of the cornea, and then the photograph is taken. If you want more data, you can do what is called as panorama, where you take center, nasal, and temporal, three frames, and they are fused together to give you a combined photo. And then sometimes, if you don't get proper photos in these two, you can take peripheral photos also, like I have shown here. Now coming to the quantitative analysis. So first parameter that everybody is kind of stuck to when they talk about specular is what is the cell density, what is the cell density. So cell density, we all know, varies with age. So basically, endothelium is a monolayer which is made up of about 350,000 to 500,000 cells. The normal density in adults is about 2,500 cells per millimeter square, and it reduces by 0.6% per year. So the cell density has to be compared with a particular age group, as we have shown here in this table. So remember, in patients who are above 80, even a 1500 cell count can be normal. Next is pleomorphism. Now, what is pleomorphism? We all know that normal endothelial cells have a hexagonal shape. So if there is a disruption of the hexagon, this is what will lead to pleomorphism. So in general, if there is a significant, if there is more than if the number of hexagonal cells are less than 60%, then we will tell that this is basically a clinically significant pleomorphism. And because of this, you can have effect on the fluid barrier function of the endothelium, which means that if there is a pleomorphism present, there is a increased chance of postoperative edema. Now, this is how a pleomorphism graph is plotted. So you can see that this patient has a hexagonality of 53, which is reasonably good. And this is the 6-side cell, so almost 53% are having six margins, and this is pentagonal, and this is 7, 8, like, and so on. So this is the graph, corresponding graph that can be seen. Now coming to polymegathism. So what is polymegathism? Polymegathism is basically what happens if the endothelial cells die because of natural issues or because of some insult. So the adjacent cells actually move in to fill the gap vacated by the sloughed cell. And endothelial cells either stretch or slide into a different position, and this movement creates a variation in the cell size. And this is actually called as polymegathism. The rate of polymegathism is denoted by what is called as coefficient of variation, or CV. Now, in general, CV values less than 0.31 is considered to be normal. This has to be made note of. And again, you can see here in the form of a graph. So you can see this patient has a very good CV value, almost 28, less than 31. So you can see that most of the cells are around 400 microns, 200 microns. So this is considered to be a good CV value. Next, coming to the qualitative assessment. So before we start the qualitative assessment, I think all of you just look at this photograph, and you can see three things here. You can see corneal guttata, you can see pseudoguttata, and you can see endothelial degeneration. Now, when you do a specular microscopy, all three may appear same. So the point is, how do you differentiate and how do you proceed further? So first, coming to the guttate formation. So we all know that guttate are the most common findings that you get in a specular microscopy. And it basically are seen as dark areas of variable sizes in the endothelial mosaic. As you can see here, right eye is showing more than the left eye. Now, very important to understand is dark area does not mean there is absence of cell. You will understand that it's only because guttate are nothing but these are basically Descemet's membrane excrescences which project into the posterior, into the anterior chamber, and the endothelial cells are actually lying over it. Unfortunately, because we all know that specular reflection is in a plane, so these cells are outside the plane. So that's the reason why these cells are not captured. So this black area doesn't mean that there are no cells there. It's just that it's not captured. So this is a very important point to remember. These guttate are actually formed by secretions of secretion of collagen from the endothelial cell. And you can see here, this is a guttate, and you can see that there is an endothelium present here. Okay, so it goes to 5 stages, right from the early stage, dark structure in the center of the endothelial cell, to progressive coalescence, where you will not find the normal endothelial mosaic. It's impossible to visualize. So these are the 5 stages of progression. Then there is something called as pseudoguttata, which actually looks like a guttate. Exactly, that's what I told you. But they are nothing but actually edema of the endothelial cells. But most important is it is transient and it is reversible. Adjacent cells are not affected by pseudoguttate. So here you can see that over a period of time, over a period of just 4 days, from such a significant pseudoguttata, it has become actually normal. So this can happen in various conditions, like right from infection, inflammation, medication toxicity, and many other conditions which can induce this pseudoguttate formation. Now let's come to some typical conditions like iridocorneal endothelial syndrome. Now, iridocorneal endothelial syndrome is essentially the endothelium loses its character, and the cells are actually called as ice cells. And what is classical of these cells is they have a black central area with a white border. That's called as a reversal pattern, and they can start with a group, and ultimately the whole endothelium may be replaced by ice cells. So here you can see a normal endothelium here, and you can see ice cells here. So you can see white border with a dark center. So this is very important because this is what is called as reversal thing. And here in the same endothelium, you have a normal endothelium and you have ice cells. So this is a transition zone, and you can see white centers and dark borders. Okay. Now, another important condition is posterior polymorphous dystrophy. Here you can see dark rings around the around the lighter center, in which there are some cellular details visible, and some other conditions can also give rise to changes. For example, a contact lens wear, you can have short-term changes like endothelial blebs that can be visible. In the long term, you may have polymegadism, which becomes irreversible. Glaucoma causes decreases in endothelial cell density, and changes also happen in glaucoma. Now, let's look at some examples. Now, this gentleman has come for a cataract surgery, dense cataract, his age is almost around 70. And what is happening to his specular microscope? So this is the right eye. This is a center capture position. You can see the face endothelium. Now look at this. Now all know corneal thickness is ultimately a measure of the endothelial function. If the endothelial function is not good, the cornea will start to thicken. So any abnormal corneal thickness beyond 600 microns, you probably think that there is some problem with the endothelial function.
Oh, the
density is pretty good, but the CV, it's 28 only. The quality is 65. So this is essentially almost a normal specular for that particular age. So this patient, you can I think we need to mute the thing. Hello.
AJ, can you mute everybody else?
So now what you see on the right side is a normal, and see the now if you on the left side you have dark center with a white margin. So these are typical ice cells. So this ice is typically a unilateral condition, and if you see this, but if you don't see the endothelial map and only see the parameters, you would think so that it is absolutely okay. But that's the reason why you have to see both the map as well as the parameters. Now, the most common scenario is this, where you have a patient coming with cataracts, clinically visible, and coming for cataract surgery. What do? So this is a patient who has come for a cataract surgery, and these are the values. Now, the CCT in one of the eyes is 478, which is very good. Other eyes, CCT has not come. See the cell density, 3,428. Another eye, cell density is 3,072. Now, one thing that you have to remember is that in an auto analysis, the machine will give you cell density even with the smallest number of cells counted. Now, what you see here is N is the number of cells which have been analyzed. So, see in the lower part, it's only 28 that has been analyzed, and still it has been able to come up with a. If you had seen this report and just gone by the cell density, you would have ended up with a disaster, because this patient has a very poor CV in the left. It's almost 126, and there are hardly any right there also.
Maniji, can you mute everybody else?
So
Maniji, can you mute everybody else?
One important point from this presentation, it would be don't depend on cell density, because in presence of guttate, you will get variable cell densities. Now look at this picture. You have cell in this area, you're getting a density of 893. In this area, you're getting at 2241, and in this area, you're getting at 1825. So why this is there? Because guttate density itself can be vary in the endothelium. Number one. Number two, this cell density does not equate to the endothelial cell function. So this is very, very important to understand, that don't go by it can have variation. So measuring cell density is inaccurate, and the reason is here. You can see that all the three pictures have got the same cell density, but see the CV value, which indicates the cell shape. So you will be very comfortable in operating this patient rather than operating this patient because the CV is quite high. So this patient will have more chances of having corneal edema in the post-op period. Now, Fuchs endothelial corneal dystrophy is the question when if the patient has Fuchs, where you do a combined surgery or a standard cut. For this or clinical definite edema. So this is the classification that has come up in this paper, which speaks about 3 stages of Fuchs. One is without edema, second is with clinical subclinical edema, and the other is with definite clinical edema. Definite clinical edema can be made out in slit lamp, but for subclinical edema and to rule out that there is no edema, new modality, diagnostic modality has been proposed, and that's called as PENTACAM. We'll be discussing that. In this, the important thing that you have to understand is there are 3 pointers towards which tells you that there is fluid in the cornea. One is, if you see this patient in 2012, this is the corneal thickness map. You can see nice circular rings in the corneal thickness. This is absolutely normal pattern. Now the same patient 18, you can see circular, this become irregular. The circle present denotes the thinnest point on the cornea. And third point is the back surface. You have something called as a back flow. That means there is one area in the posterior layer of the cornea which is projecting towards the anterior chamber, and that can be picked up as a red spot. So these 3 pointers tell you that the patient has subclinical edema, and that's where you will not take the patient for only cataract surgery. You will do a combined surgery. Another pointer is, if you get 2 eyes checked, and if you find that there is a significant difference between the central corneal thickness, the patient which has higher central corneal, the eye which has higher central corneal thickness has a relatively poor endothelial function. So probably this patient is already going in decompensation. So this might also need a combined surgery. So combined surgery you will do in clinically if you find that there is variation in the symptoms, patient find it more difficulty in the morning. If there is asymmetric and progressive increase in CCT, and if you have evidence of edema. So to conclude this talk, I would say that it's very useful to differentiate different corneal conditions and in predicting prognosis also. And it's very useful to plan adequate intraoperative measures. It's useful to decide what IOL you will put. If you have guttate, never put a multifocal IOL because patient will be very unhappy. So this is what I wanted to talk about the specular microscopy. So we will discuss now, or you want me to discuss at the end?
Do it at the end.
Do it at the end? Okay. So let me start the second talk. Anything Somana would like to add? I think Somana can really throw some light from a cornea specialist perspective.
No, sir, you have covered everything.
Dr. Sumanna, you can pick up questions from the chat box, and you can ask Dr. Sagar. Can you see the chat box?
One question is, what is the cutoff value of endothelium cell count for intraocular surgery?
Yeah. So if there are no guttate changes, as you can see, so any cell count less than 1000, definitely it's a no for a intraocular surgery. 1000 cells per millimeter square. If there are no guttate changes, as I told you, because presence of guttate changes, the cell density is inaccurate. Okay. Is my screen visible now?
Yes. There are 2 more questions.
Yeah. So we will finish it off.
Can you see it, Dr. Sumanna?
I cannot find it. Just
What
give
is
me 1 second. What is the indication of peripheral photo in qualitative analysis?
Yeah. So sometimes you have central guttate changes and it's very difficult to get an image. So you still want to understand what kind of cells the patient has. So that's the reason when you would take a peripheral photo to understand just the quality of cells, nothing more. You're not looking at the cell density, you're basically looking at the qualitative assessment. So mainly in the presence of guttate changes. So if you have mild guttate changes and you are not able to pick up specular in that area, you can take a peripheral photograph and check the other parameters like hexagonality and coefficient of variation.
Okay, another question is, what will happen if the polymorphism is more than 50%?
Okay, polymorphism. So you're talking about hexagonality. So hexagonality, if it is less than 50%, that means you are looking towards a little poorer quality cornea. So when you have these values which are little borderline, which are not absolutely normal, then when you do the surgery, you have to do surgery with a lot of care. You have to basically do low parameter surgery. You have to protect the endothelium by using dispersive viscoelastics. We also use BSS plus instead of normal BSS. So basically you have to create an environment during the surgery which is least injurious to the endothelium. So that's the main thing. And second thing is you can pre-warn these patients that they might have unexpected corneal edema in the post-op period, which might take a little while to resolve. So a lot of times you may have unexplained corneal edema where you think that you have done a very good surgery and there is nothing abnormal about it to produce a corneal edema, and you end up having a corneal edema on day one. So that's where this specular would have given you a clue. So basically you need to take some extra precautions. That's all.
Okay, I think that's all, sir. That's all for this section.
Yeah, so we'll start with corneal topography.
Yeah, I think so.
Okay, let's begin. So Dr. Satyajit was mentioning that those who want to do cornea and stuff, they definitely this topic is important. I beg to differ with him. The reason being that few years back, probably people who wanted to do cornea topography, learning topography was definitely an option. But now I think everybody who does a post-graduation, this is a necessity, absolute necessity, because you will be, the number of indications that are required now where topography is indicated have increased significantly. Okay. So right from diagnosis of ectatic conditions to screening pre-refractive surgery patients to monitoring certain common corneal conditions like pterygium to improving your IOL cataract surgery outcomes. So most of you want to become good cataract surgeons. You want to put premium lenses. Topography is an integral part of your assessment. Then you will have a lot of patients who will come to you who have undergone refractive surgery and they want the lens. So you would need topography help to do their IOL power calculation. So it's no longer an option. It is a definitely necessity. So this can be done with the help of a Placido-based system, which assesses mainly the curvature of the front surface, and elevation-based system, which essentially gives information about overall structure of the cornea. Now, elevation-based system can further be divided into scanning slit system, example being OpScan, and Scheffler-based system, which is PENTACAM, which is the most common used modality now. Now, most of the topography machines that are available now come in combination with biometric. So commonly used biometrics will have a topography machine inbuilt. So you should be able to read topography machine to maximize the information that the biometric gives you. Now, the principle of topography is basically Placido principle. You basically give you basically shine multiple concentric rings on the cornea. The reflected image is captured by the topography machine. An ideal sphere will be one which will have Myers which you can see on the cornea equally spaced. But this Myers, actually the distortion of the ring patterns will be the basis for the calculation, and spacing between the rings will give you what is called as radius of curvature. So closely spaced rings will give you higher curvature, and a widely spaced rings will give you flatter curvature. Remember this, very important. Now, once the analysis is done, what the computer does or the machine does is each point it will give you a value, and that value is converted into a color-coded map. And this color would depend on the scale that we use. So, in general, remember this: higher the value, it will be in hot color. Lower the value, it will be in the cold color. Now, So suppose this image is given to you in an exam, and they will ask you describe this image. So this is what you need to understand this. You need to understand few things. You need to understand what map has been used, what scale has been used, what is the pattern that has come. So if you were to describe this image, so you would say that this is a topographical image of the left eye showing an axial curvature, and the scale used is absolute scale, and it gives a pattern called as symmetrical bow tie astigmatic pattern. So this and this is of the left eye. We will describe this in this way. Now let us dissect each component properly. So when we talk about the absolute scale is the most commonly used scale. Across all the topographies, you will have the same absolute scale, same gradation. It starts from 9 diopters, it goes up to 101.5 diopters. The central area is divided into 11 gradations of 1.5 diopter intervals each. Beyond 11 gradations is about 5 diopter intervals. The important thing is that you can use this data and compare it with the previous exam done on a different machine, but the scale has to be absolute. So within the same scale, you can compare. The only drawback is sometimes it can miss subtle local changes in the curvature. Now, normalized scale is essentially that you use a set of colors to automatically fill the dioptric range for that map. So you will have narrower steps, but the problem with using normalized scale is you can exaggerate normal patterns and it may look little abnormal. Now you can see this patient. This patient has a simple astigmatism, and on an absolute scale it shows one yellow spot. But when you shift it to a normalized scale, see how it exaggerates the pattern. So it looks like something abnormal is there. So basically it exaggerates, and that's the reason why it's not very commonly used. The second point is what is the type of curvature that is available. So there are two types of curvature. So remember one thing, axial curvature is what we use most commonly because it gives overall shape of the cornea. So it is less accurate for periphery. How is it calculated? It is calculated in respect to a axis. So there is an axis which runs from apex, and each point on the cornea you draw a tangent, and from that tangent you draw a perpendicular to that tangent. So this is AB. So AB is the radius of curvature, and from radius of a curvature you take out the dioptric power. So like this you calculate the sagittal curvature or axial curvature. Now what is tangential curvature? So tangential curvature has nothing to do with the reference axis. It is basically localized curvature, and it is done with the help of is basically you draw circles at each point, and so that point becomes a part of the circle, and you find out the radius of curvature of that circle, and that becomes the tangential curvature thing. Now why tangential curvature is not very popular is because if you see this photograph on the sagittal curvature, it's absolutely normal looking symmetric bow tie astigmatism. But you look at this, you can have extra hot spots. So basically what it does is it creates noise in the map, so which can divert the attention from the main findings. But it is very useful when you are talking about keratoconus, because keratoconus makes localized elevations. So for a localized elevation, it's very useful to delineate where exactly the cone is. So same patient with a sagittal gives a bigger picture, bigger area of steepening, but here you give a precise location and the size of the cone. So this is how you use, and this is how you convert diopter into this is how you get diopter values from the radius of curvature. Now when we do topography, you get different topographical patterns. This is a very commonly used photograph. I think each of you should see this photograph and understand what all patterns are there. We will see them in actual real sense. So whenever you see a topography, first thing you will ask yourself is whether the shape is symmetric or not symmetric. So these are the examples of symmetric shapes. So you have these are spherical corneas. Then you have this is a cornea which shows oblique astigmatism. This is the cornea which shows steep axis along the horizontal meridian, and this is an oblique astigmatism again. So these are all symmetrical patterns, these are examples of asymmetric shapes. So as you can see directly that you will have area in the graph which is either abnormally steepened or flattened, or it produces a pattern which is a typical of a condition. So this area, this image shows superior steepening. This image shows steepening starting from the center going to the inferior. So, and then you have irregular pattern. So irregular pattern is where you cannot really define the shape, and this is typically seen in scars. Now, topography can be used to detect ectatic conditions. Of that, the most common is keratoconus. Main advantage of topography is that you want to pick up keratoconus early from the surface signs. So the earliest signs of keratoconus in thing is what is called a skewing of radial axis. Now, to understand this, you have to see this. There are two lobes of the astigmatic pattern here. One of the lobes is shorter, the other lobe is bigger. So when we talk about the axis, the line has to pass from the center of the lobe. If now it is passing from the center in this lobe, but here you can see the lobe is actually tilted. So this tilt produces a particular angle which should have been 105, but actual thing is it at 140. So this gives you a degree which is about more than 22 degrees. So this is around 25 degrees. So any tilt which is more than 22 degrees, we call it as significant skewing of radial axis. This is a very important sign of early keratoconus. Another sign is inferior steepening. So when you talk about 3 to 4 mm zone, you basically mark two corresponding points on the topography, and if the difference between the inferior and superior is more than 1.5 diopters, this is another important point to we pointed towards early keratoconus. Let's see another example here. This is a patient who has come for a test. You can see a huge area of steepening here, and this is giving on the right side certain screening indices, and these screening indices are basically pointers towards a presence and absence of disease. So there are many such indices which are available in most of the machines, and based on the indices you have index scoring system, and the machine itself will tell you whether there is evidence of clinical keratoconus based on the calculations it does. So this is a patient with a moderate keratoconus. You can see the steepening has increased, and this is a patient who has a very advanced keratoconus. You see, whole of cornea has become steep. So there is a big projection there, and this is typically seen in advanced keratoconus. Now, what is this? This is a kissing bird sign or a cat claw sign, which is typically seen in pellucid marginal degeneration, and this is basically causes a very high against the rule astigmatism steepness along this axis. Now, what is this? You can see a small, big area of blue zone. Now, remember I told you blue zone, anything which is in cold has a lower value. So this is basically an area which has got a very low keratometric power. So this is usually typically seen in myopic refractive surgery, where the whole corneal curvature you flatten it out. So this is typical of a post-refractive surgery. Now let's look at at a common condition. Yesterday we had a pterygium class. So Dr. Shantanu Mitra was speaking about corneal topography. Let's see how it helps. Now you look at this pterygium. This is a patient who was one-eyed, had this temporal pterygium. So we started following up this patient, and you can see that this temporal pterygium is producing a flattening in the peripheral area. So at this point, we are actually not bothered. We want to observe this patient to see whether there is a progression in the thing. Now see what happens. Over a period of time, the degree of flattening has increased, and it is encroaching about 3 millimeters or in the pupillary zone. So next, if we don't do anything, this will definitely reach the center and it will cause vision problems. So we remove the pterygium and see the regularization of the corneal surface. So that's how topography helped us to take the decision at the right time. Now toric is very important to do a topography in this, because it helps you to understand whether the astigmatism that you are dealing is it regular or irregular. So we have to understand this, that toric IOL basically corrects keratometric astigmatism which is regular. So very important. So when you do a topography in these patients, you basically get a visual impression of the patient's cornea. You understand that where is the steep axis of the patient, and that steep axis is your axis of the IOL. So now look at this. So what you see here is basically all regular examples of regular astigmatism. So this is against the rule astigmatism, this one horizontal, this one is vertical, that is vertical is steep. So this is with the rule astigmatism, this is oblique, and this is a very high against the rule astigmatism. This lady had a this gentleman had a almost 5.5 against the rule astigmatism, for which we used a torical and had a very good outcome. So this topography actually helped us to make a decision that this is a regular astigmatism. Now, when I say irregular astigmatism, what do I mean? I mean that if you get two lobes and one of the axes don't pass to the other lobe, there is a sagging of the lobe. This is what I call as little irregular astigmatism. Similarly, to look at this patient, this also patient had a pterygium excision done, but there is a little bit of tilt of the lobe. So these patients will benefit from torical, but the predictability of the outcome is less compared to the ones which I showed you before. Now look at this example. Now this patient is a very interesting patient. Patient was not wearing any cylinder in the glasses, but keratometric astigmatism was 3.5. When we did a topography, the astigmatism came as 3.8. Now when we saw the map, you can see that there is a hotspot here. Now this hotspot is encroaching the 3 millimeter zone. That's the reason why the topography has picked up it in K1 and K2. And have we not? And when then we again went back and correlated this, there were subtle opacities which were present in the anterior stroma that was responsible for this hotspot. So this patient underwent a standard cataract surgery without a normal IOL, and he didn't need any cylinder. So this topography actually helped us to decide that this patient will not need a toric IOL. Now these are all examples of irregular astigmatism. In this cases toric IOL has actually no role. Now, with so much of information that you get from Placido-based system, why it has lost its popularity? The reason for that is that the eye that you test in topography. Now, just look at this. This is the same patient, same eye, done in 15 minutes gap. So here you get a regular astigmatism, here you get an inferior steepening. Now, why this is so? The reason is because topography assumes that each eye it is testing is a Gullstrand's reduced eye model, where the line of sight coincides with the visual axis and it crosses the center of the pupil and up it. That means all the axes are aligned with the measurement axis of the topography machine. That is not the case actually. A lot of people have this equation can get distorted if you have misalignment while capturing, or if the patient has significant angle kappa, where the patient is not looking from the center of the cornea. This can give rise to what is called as false steepening on topography. So this is a false steepening. This is a false sign. So this is one of the reasons why topography has fallen out of favor, because it's a reference-based system. So it basically whatever the reference it gets, it will basically calculate from there. The second reason why this is that if you see this topography, it's absolutely green. Everything looks on green, but when you do detailed assessment of this patient actually had an elevation in the posterior corneal surface, which was picked up in Scheinfeld lens devices. So this will not pick up, this Placido-based system will not pick up posterior keratoconus. You will, if you don't do a proper assessment. That's the reason why Scheinfeld-based systems have come. Now, why posterior keratoconus is important is because it starts in an area in the posterior layer with one protrusion. So what the device needs to do is basically device needs to find out how much is the elevation here and corresponding how much is the reduction in the corneal thickness. So these two things the device has to tell you, and this is possible in Scheinfeld imaging. So essentially this is why PENTACAM or there are certain other devices which are based on Scheinfeld imaging has become very popular. So here essentially you have a rotating camera which takes sections of the cornea and the anterior segment, and it reconstructs a three-dimensional image from which various parameters are taken. There are close to 30 parameters, and if one had to see all these parameters, it is practically not possible. One has to remember in PENTACAM analysis, there is no single parameter, but it's a combination of findings that's important. You have these, so if you forget about everything, if you just use these three maps, which I'll explain you will be equipped enough to diagnose most of the things in Scheinfeld. So this is how a 4-map refractive map comes, and it comes with 4 maps with the sagittal front curvature, elevation, front and back, corneal thickness, and certain values. So here is the patient's details which are mentioned. Then you have corneal front, corneal back, pupil values, and certain other parameters which are also useful in certain indications. So let's come. So first thing that you will probably see is that whether this graph is acceptable. So you will look at what is called as QS, or quality specification, and if it says okay, you can go ahead and assess this patient. Next is Q value. Now Q value is essentially nothing but the measure of asphericity of the cornea. Now we all know that cornea is a aspheric surface. That means you have more curvature in the center, and as it goes in the periphery, it flattens out. So if you have a absolute sphere, you will have a Q value of 0. But our corneas are usually prolate. We call it as prolate because they are having curvature, a flattened curvature in the periphery. So you have a value in normal corneas between minus 0.2 to minus 0.4. And this Q value, if it is increased, that means the central area keeps protruding out. That means the patient is either developing steepening, which can happen in keratoconus or ectatic disorders, or the patient has undergone a hyperopic LASIK. Okay. See the other side. It's called as oblate. That means the cornea is flattened. You will get plus values. So this you typically see in a patient who has undergone myopic correction, where the central cornea gets flattened. So Q gives you the shape of the cornea. Next thing you will glance is what is the maximum K. So maximum K, if it is more than 48, that should alert you or alarm you that something is wrong in this thing. So not every patient who has more than 48 can be abnormal, but it's a good pointer towards for you to look at the map more carefully. Now, sagittal curvature we have already seen. The next important thing that you will see is the corneal thickness map. So what is corneal thickness map is nothing but point by point corneal thickness assessment by the machine, and it gives you a value like this. Again, this is color coded in the based on the scale that is shown here. It's an absolute scale for the thickness. Now, when you see this, you have to see this with these measures here. So what are these measures? So you have something called as a Pachy apex, which is the centermost point of the image, and from that you have to find out what is the thinnest local. Now this is denoted by a circle in this thing. So thinnest local is the most important point that you will look. Thinnest local is the thinnest corneal point on the cornea, thinnest point on the cornea, and you basically look for the vertical or horizontal displacement. A vertical displacement is given by Y value, and a horizontal displacement is given by X value. And similarly, a plus and minus sign is given based on where the thing is there. So if you have a vertical displacement of more than 0.5 minus, that means there is a vertical inferior displacement of the thinnest point. It is of big significance. So here you can see that example. So in a keratoconus, that's what happens. You have a paracentral area of thinning, and as the cone increases, there is a shift of the thinnest location downwards. So you get here a value of around 2.33. That means it's pretty more than 0.5, obviously. So this is something which is very significant. So next we come to elevation. Now elevation is a concept which is a little difficult to understand, but I'll try to explain you this. So basically, when you want to pick up any irregularity on the corneal surface, whether it's a front surface or a back surface, you need a reference surface. Now, how that reference surface is created is created by the machine only, and it is basically based on the raw data that the machine has for that particular patient. So it creates what is called as best fit sphere. So this is what it creates. Now, what is this best fit sphere? It's basically nothing but a surface which it will basically apply to the front surface of the cornea and to the back surface of the cornea. So now each point is actually compared to this reference surface, whether that point is above the reference surface or below the reference surface. Now for ectatic disorders, you want to find out which are the how much above it is from the reference surface. So it is denoted by a plus sign, and below the reference surface is denoted by the negative sign. So now you see this map, you can see this yellow color thing is the reference surface. So you can see this area is above the reference surface. So this is denoted by a plus sign, and these are the areas which are below. This area is below the reference surface. This is denoted as minus. So this is the concept. And what happens in a keratoconus? Now this is the front surface of the cornea. So area of the cornea will be above the reference surface, and that is called as positive island of elevation, because all the points in that area will have plus power, and depending on the value of those points, suppose so the magnitude of the elevation, it will give you a color coding. So if it is very high, it will give you a red codation. So here now, what is important is what are the normal values for elevation. Now previously we used to say that any value above 15 in the front surface and above 20 in the back surface is significant. Nowadays we use this criteria more, where we look at the thinnest point, as I showed you, the elevation at the thinnest point, so on the front and the back. So if it is more than 5 and 12, it is of significance. Now we come to another important map that's called as Bellin's embrasio-ectasia map. Now this map came in because there are certain patients who have subtle ectasia. So you don't want to miss those patients. So what it does is we will basically study these three maps in Bellin's embrasio-enhanced ectasia scale. So what it does is basically when it's calculating, it basically gives you a new reference shape or a new reference surface. Remember this. So what it does is it basically gives you a new reference surface which is much flatter than the original reference surface. And how does it do it? It basically removes the 3.5 mm zone around the thinnest point from the calculation. So you get a new reference surface which is much flatter, so that you can easily find out ectatic areas which might get missed with the old reference surface. So I'll give you an example. Now this patient shows this is the front elevation, this is the back elevation. Some changes are there on the back elevation. Now when you apply this new reference surface, you can see that the back elevation shows significantly higher hotspot here, which was not very clear in the old reference surface. So this is how it makes it significant by putting a new reference surface. It also gives you these 5 parameters, and these are basically deviations from the normal that are calculated by the machine itself, and any deviation from the normal more than 2.6 standard deviation will be color coded as red. Anything which is around 1.6 standard deviation and above will be coded as yellow. So here you can see all the values are red. D is the final D, which is taken out from all these values. So D, we look at D as a total, as the most important factor in analyzing this map. So there are certain guidelines to be followed when you are advising patient for LASIK procedure. So based on the age, the final D value should be less than 1.6 if you are taking up a patient for a refractive surgery less than 30 years of age, and it increases to almost 2.2 for a 40 years, and it is more liberal for surface ablation. So final D is a very important parameter to now look at. Now another map is thickness profile. Now we all know that the corneal thickness increases from center to the periphery. So this basically map is based on that concept. So what happens is you can see these dashed lines here. So these dashed lines are basically normative data, 2 standard deviations of normal population, and the red mark is of the patient. So patient's value will basically fall between these 2 red, dotted lines, and they should run parallel. If there is a dip before the 6 mm zone, then this is abnormal, as you can see in this particular thing, this particular graph. So this dip, if you see, this dip has happened before the 6 mm zone. So this is an abnormal finding. So why this dip has happened? Because the thickness has not followed the normal pattern. There is some element of thinning in the mid periphery. That's the reason why the graph has come down. Topometry map is another map that we need to look at, and there are indices like the topography indices, and one can look at those indices, and again they are color coded, and that will give you an idea. So this becomes the 3 maps that you will study in thing. And the last thing that you will do is basically do a inter-eyes asymmetry. Now remember one thing, that there is symmetry between the 2 corneas, and if there is some amount of asymmetry, that has been studied very thoroughly, and you have a point scoring system and whatever we have seen just now, that can be compared by using this asymmetry score. So this is another part. Now let's look at an example of a patient who has come for an evaluation with a 23-year-old. The right eye is okay, the left eye is not improving further. Left eye has a cylinder of -3 with a at 130 degrees. Now you are suspicious that why it is not improving, so you order a PENTACAM, and this is what comes in the PENTACAM. Now what we have just now studied, we'll try to apply that. So this is a patient's name and other things. So let's see first the quality specification. So the image is okay. See the Q value, it's around 0.25, which is absolutely normal. And now you look at the maximum K. So maximum K is 45. So in the right eye, things look more or less okay. Now see the left eye. Left eye, there is a yellow area there. That means there are data gaps. So there is some issue when the image was being captured. But this usually typically happens in patients who have significant abnormality in the cornea. But see the Q value. Q value has increased. As we had discussed, that as the ectasia increases or as the steepening increases, the Q value will increase. Look at the K front max. It's almost 55. So there is something abnormal that is definitely going on. Let's look at the sagittal curvature map. So you can see that in the right eye, you have an area of steepening here. And in the left eye, there is a significant steepening. You can see it's an asymmetric bow tie with an inferior steepening, and a steepening is very, very significant. Values are almost 53, 54. Let's see the corneal thickness now. So corneal thickness, the most important thing that you will see is the thinnest point. So this is around 463 and this is around 406. So this is definitely much lower. Remember, any corneal thickness less than 470 has a significance. 470 is a cutoff for us for refractive surgeries. We never go for procedures below 470. So here you have 463 and 406, and see the difference between the two eyes. See the Y value. That means the inferior displacement of the thinnest point is almost 0.63. And see the left eye, it's around 0.80. So there is a significant inferior displacement. So there is a definite abnormality. See the elevation values at the thinnest point. In the right eye, it's +4 and +4. We need 5 and 12, as I told you. But see the left eye, it's almost 25 and 60. So this is abnormal. So there is definite ectasia. Now look at the balance thing. The balance here is, and the right eye is normal, but the final T is around 1.77, which is borderline. As I told you, this is yellow, so 1.6 standard deviation is more. So, but see the left eye. See the left eye, you can see a huge amount of ectasia here in the balance, and the value is almost 9.92. Topometric indices in the left eye abnormal. So just to sum up, so axial map abnormal in both eyes, thinnest pachy abnormal in the left eye, Y displacement is abnormal in both eyes, elevation point is normal in the right eye, abnormal in the left eye, balance is borderline in the right eye, abnormal in the left eye. Topometric analysis is abnormal. So this is a patient who has absolutely established keratoconus in the left eye and has probably a subclinical keratoconus in the right eye. So just to sum up, these are the things that you will look into when you are doing a PENTACAM analysis. You will look at the general parameters, you will look at the anterior sagittal curvature, elevation data, balance and ratio, corneal thickness profile, and inter-eye symmetry. There are many other uses of PENTACAM. Of course, it will need another class to actually discuss all these things. But you get something called as a posterior corneal astigmatism, which is useful in some patients definitely, because it can have an effect on your toric aisle calculations. Nowadays, most of the toric calculators come with a value which is presumed corneal astigmatism. In PENTACAM, actually you get the actual posterior corneal astigmatism. Then you have, as I mentioned, post-refractive IL power calculation is important. And you also get aberration profile of cornea, which will help you in deciding about multifocal IOL, whether we can implant or not. And it also and about the toric aisle, as we discussed. So I think with this, I think I should stop, because I don't want to give so much of stuff that it becomes very confusing. We can discuss.
That was a very nice presentation. Dr. Sumanna, you're there?
Yes, I'm here. I'm just seeing if anybody has posted any questions.
So what I will suggest all the postgraduates is that from tomorrow, if you get a patient who comes with a topography map, start looking at it. At least the axial curvature map, start looking at it. See the pattern that you are getting on it. Try to see with that pattern map that I showed you, which pattern it fits in. So that will be your first step towards actually understanding topography. PENTACAM needs a little bit more of application, so it will come with time. It's not easy. I understand this explaining PENTACAM in half an hour and getting everything done. But of course, Dr. Satyajit Sinha is very kind enough. He'll be uploading all this presentation on YouTube. So you can probably need 2 or 3 times. You can see this presentation, and most of the things will be very clear once you make a notes of this. And what I told you is a very, very precise point-wise application. And if you follow this, I'm pretty sure that you'll be able to pick up early ectasias, abnormalities in cornea. Okay.
So there are 2 questions.
Sure.
One is, what is difference between tomography and topography?
Yeah. So topography essentially is the surface study. So topo is basically you're just assessing the corneal surface, the front surface of the cornea, and tomography is essentially 3-dimensional study of the cornea. So you are basically studying the front portion, the whole of cornea in total, both the anterior and posterior surfaces. That's how you differentiate between topography and tomography.
There is another question, that is whether axial curvature and sagittal curvature both are the same thing.
Yeah, they are the same. They are basically, the term is used interchangeably. You can use either term. They are the same. Absolutely.
Okay, sir. There are no more questions, I think, on this topic.
Sumana, anything you would like to add from your point of view?
One question, Dr. Sumanna.
Yeah, no, I don't. What can I add more? Well, sir has given such a crisp discussion. What I want to highlight in every keratoconus patient, what I have observed, the quality specification is always comes as data G.
Correct.
So we have to take it as it is. We
Correct.
cannot take it like if it is not showing okay means we are discarding the PENTACAM. That is not the thing.
Yeah. So when the data gaps is coming in a normal patient, that's when you need to repeat it. If you have an abnormal patient like what I showed, you can very well take that map. So the issue comes when there is data gap who is coming in a patient who is coming for a pre-refractive workup or checkup. That's where you need to repeat the test.
Right, sir. Very comprehensive talk, sir. Thank you.
One more question is there.
Yeah. I'll check. That is, the question is, normal cornea Q value is negative and normal cornea has positive spherical aberration. Is it any correlation?
Yeah. So this is a very common confusion that a lot of people have. So basically, spherical aberration is a different issue altogether. Spherical aberration is essentially a component of corneal aberration, which is measured by a aberrometry. Please remember one thing, this is a totally different concept altogether. Q value is essentially nothing but just the shape of the cornea. So spherical aberration, you actually get what is called as Wernicke's polynomials, which are obtained, and in that you get what is called as spherical aberration, and that value is what, but again it is linked to the shape of the cornea. So you are basically quantifying it in the form of aberration. So two things are not related also, but they are totally you cannot be used interchangeably. That's what I want to tell you. So shape of the cornea is what we say as the Q value.
There is another question that when to ask for the topography, like what degree of myopia or astigmatism when you will ask for a topography. Okay.
Yeah. So that's a very good question. For a myopia, obviously you don't ask for a topography, it's not indicated unless a patient is keen for a refractive procedure. But for an astigmatism, as I showed you there, if you have some early signs, if you get a Caesar reflex on retinoscopy, or you are getting doubling of Myers on the keratometry, or you are not getting best corrective visual acuity, improving to 6/6, then you have to order a topography to see what is happening. So any unexplained visual impairment, a topography is must. Preoperative is a different group altogether. Even for children, 14-year-old, 15-year-old, there is no reason why they should not have a 6/6 vision. Or if you look at their history and they have a 6/6 vision at 12 or 13 years of age, at 15 it becomes 6/9, 6/12, and it's not improving with refraction, you have to go for topography.
Okay. No more questions, sir. I think no more questions are there.
There's one last question I can see, which is superior, PENTACAM or OPSCAN. Now, OPSCAN is not something which is easily available now, but OPSCAN was the first instrument which actually highlighted the importance of posterior corneal surface. The issue with OPSCAN was especially the post-LASIK patients, it used to give a lot of hot spots, and a lot of patients were picked up as post-LASIK ectasias on OPSCAN. So OPSCAN, very good instrument, but as of now, availability is an issue. So PENTACAM definitely as of now is the device of choice between the two. Second version of OPSCAN is available, but I don't know how many centers have it.
Okay, thank you very much. Thank you, Dr. Sagar, for the wonderful presentation, and thank you, Dr. Sumanna, for the wonderful moderation. Dr. Sumanna, we'll be seeing you tomorrow again.
Yeah.
Yes, thank you. So,
okay, sir. Thank you.
Tomorrow the presentations are on penetrating keratoplasty and lamellar keratoplasty, which will give a full description. So we'll have that talk tomorrow. But this talk is definitely, as Dr. Sagar Bhargav said, you need to listen to this talk many, many times again, which we'll send you the YouTube, and then slowly the concepts will become clear to you about topography and tomography and all those things. Thank you so much, all the postgraduates, and very soon we'll be, within today or tomorrow, we'll be putting up all the YouTube links of glaucoma, retina, and squint. And once this cornea is also over, then we'll put this also. After the cornea gets over, we'll have a 2-week break again, after which we'll start again with cataract, uvea, and neuro-ophthalmology. Once again, I would like to thank Intas, Mr. Manish ji, who is always there with us in the evening, coordinating this. Thank you so much to Intas Pharmaceuticals. And once again, thank you, Dr. Sagar Bhargav, and thank you, Dr. Sumanna. Thank you so much.
Thank you, Dr. Sajid.